Hi there, I'm Arthur Cummings and I'm with my son Brendan Cummings. It's a privilege to be on this call with him. And we're going to be speaking about UBM with AI on top of it and a product called ICL Guru. And how we've integrated that into our practice recently and the differences that it's brought about. Brendan.
I think something that'll be very interesting to go through is you've used ICL for a long time. How has using UBM and AI and the ICL Guru changed the way that we do sizing? How do they compare?
Oh, it's chalk and cheese. It's very interesting. It's always painful to think about what we did early on. But early on, all we really had was the guidelines from the company. We never had any huge problems, but we always did a case and you were wondering what you're going to get. You had no idea what you're going to get. The low volt, the high volt, small angles. There was always this question of, I don't know what I'm going to get. And then in 2014, when the Aquaport came out, that made it more forgiving. So the stress came down a little. And then we started using a formula called the NK, the Nakajima formula with OCT about 8 or 9 years ago. And that certainly improved things. It gave us more confidence. And again, not doing badly, but still getting surprises, low volts or very high volts. And I'm more concerned about the angles and the volts really, but angles that again, where, wow, should I exchange this lens or should I not exchange the lens? As well as I do, because you went to the course with Sonomed and the Zoldival course and came back saying we need you to get ICL Guru. And you've seen yourself what's happening in the practice. We have doubled volume year on year almost, just thanks to the fact that we are so confident now in the results we're getting. The fact that it's so predictable it's just a different ball game. So you can almost imagine if you were doing LASIK now for the first time and you had no idea how thick the flap was going to be. That's how we started out with LASIK too. And now it's more predictable. So it's much the same sort of analogy that it's just more predictable. In so many ways, I envy someone like yourself whose first experience with ICL is with ICL Guru. That's the way to start.
I completely agree. I always think people in my generation think that the surgeons, the kind of refractive surgery trailblazers were so brave. You doing so much things without really knowing exactly how it's going to turn out in terms of flap thickness and bulk. When I came back from the ICL Guru course in Argentina, you remember I said I don't want to do an ICL until we're using ICL Guru, because when you're starting out as a surgeon, you want to limit your experience to all positive cases. You don't want to have to deal with a surprise early on in your career. And that's all I've ever known.
And you're 100% right. You want to start off well, but the truth is, no matter what stage of your career you're at, you don't want bad cases. And I think this is exactly what ICL Guru does for you, is it cuts out those surprises. There are no more surprises. I'm sure later on in this conversation, you and I'll speak about the outcomes we've got, and the outliers just don't exist anymore.
It's been incredible how predictable the volts have been. We've not had one case where we've had to exchange the ICL or even think about it too much. If we did have a higher volt early on, by 1 week, things had settled to where the ICL should be sitting.
You'd wonder why the numbers have doubled in the space of a year. And the thing is nothing more than our confidence. We're not trying to convince people of anything. Now, because your confidence is so high, I'm happy to speak about ICL at -3 and -2 and -4, where in the past, if LASIK could do it safely, it was the LASIK, because you had this concern about sizing. The only concern you've ever had really is about sizing. And in years gone by, the only time you'd think of ICL would be when you're not suitable for LASIK. Where now, as every patient comes in, knowing we don't know what they're suitable for until we've done the entire examination. And then once we know all they're suitable for, we then make the best decision for them based on their needs and whatnot, and their anatomy and their physiology.
It's part of every conversation that I have with the patient nowadays. If you think about it, doing UBM makes so much sense compared to other sizing methodologies, because we'd always used proxies to estimate where the sulcus to sulcus space is going to be. And as there's all this variation anatomically, not everyone has the same relationship between their angle to angle as their sulcus. And well, OCT helped to exclude more outliers. Actually measuring where the lens is going to be is the way to really exclude them as much as possible, to reduce it to the lowest number you can possibly get. And the beautiful thing about ICL Guru is the more that we feed it, the more post-op data we give it, the better it's going to become and the more refined it'll get. And the numbers are only going to improve in terms of accuracy.
Absolutely. The other thing is, I never once diagnosed an iris cyst before with a UBM. So you just wouldn't even know if there's a cyst that you've got to take.
It's like maybe 10% of cases we see a small one.
Exactly.
I remember very well when I went to the course. I remember I had wrote down in my diary a few things you wanted me to learn from it. And the main one was, what UBM are they using? You really wanted me to find out what UBM are the Zeldavars using. And when I got there and I saw how the Zeldavars had worked with ICL Guru and with Sonomed, it made all the sense in the world why Sonomed was the only UBM to get. The fact that it's vetting the images for us is incredibly powerful. We know that the data that's used to feed the ICL Guru algorithm is really high quality, and it's a really well-aligned scan at the right depth with the right focus. Can you imagine trying to introduce this type of technology where you don't know if the quality of a scan is good enough to feed the AI?
Absolutely. You know the phrase, GIGO, garbage in, garbage out. You have to give great data. So you're getting that from the device, but then the device is selecting the best images. And it goes through this incredible algorithm. And I think right at the end, when the sizing is actually applied, there's also mathematics applied to the potential forces on ICL itself. We've never had a tool like this, never before. Brendan, just tell me, I remember you coming back and saying, I don't want to start doing ICLs until I can use Guru. When we first introduced it into the clinic, we try to have all our nurses and techs learn it. And we figured out early on, there might be 2 or 3 who could do it. But then things changed, and you've had it done about 10 times yourself. Take us through how we introduced it into the clinic, how we got to the point where every tech can do it, and how it works now.
When we first got it, Enrique Pfeiffer came over and trained 2 of our most senior nurses. And he gave them hands-on training with our clinic manager as a model patient, and I was a model patient as well. And initially, the first 1 or 2 cases that they did, because our nurses are really detail-driven and quality-driven, the scans probably took 20 to 30 minutes to do before they were really comfortable. But that's getting used to holding the device. These were cases where they were doing it unsupervised because Enrique had left and they were responsible for the data themselves. They were being very careful. But I would say within, honestly, 2 weeks, it was down to 10 minutes for both eyes. And so we had Sophie and Tara doing it. But they started to enjoy it so much, it almost became one of their favorite sessions was to do the UBM session. They really enjoy the kind of practical procedural nature of it. And I think walking a patient through an experience like that is a way for them to express their kind of nursing ability, their caring and their guiding. So they started to really enjoy it. And then the other techs wanted to get involved as well. There have been 2 sessions where our nurses that are most experienced have trained the other 6. So they did them in 2 sessions, 3 new techs per session. I've had at least, the 2 eyes combined, I had about 15 UBMs done. And I think the updates that the Sonomed have made it easier to get higher quality scans quicker. The guidance, the color-coded guidance. But now they can all do it. Because the thing that, from a workflow point of view, is so powerful is that the ICL Guru software is integrated with the UBM. So they do it, and 2 minutes later, we've got the ICL Guru printout, and we can tell the patient if they're suitable or not for those borderline cases. Obviously, the way we do things is we want every case to be done to the highest standard. We're not only doing the UBM for very straightforward cases where we know we get an acceptable result with any sizing methodology. We want the best ICL size for every case we do, whether or not it's a slam dunk one or whether it's a borderline one. But for those borderline ones, the patient knows on the day. They have their Sonomed, and we tell them on the day, are you suitable or you're not suitable, or how suitable you are. If we can do same-day bilateral under a GA, or if we want to separate them, either do one at a time. And then that's hugely powerful. The fact that we get such quick turnaround, it's so integrated. There aren't many extra steps for them to do the sizing calculations.
Brendan, I've heard a number of patients say, and I've heard the techs say, well, and ask you as a patient who's been through it, is we did some of our cases with sedation, we do some of our cases under general anesthetic, but we do the massive majority, 90% under topical. And that the nurses and techs are almost guiding us as to what the patient's going to be suitable for. So they're saying if the patient can have the guru done and they're comfortable, then they're going to be comfortable with topical. How does that flow?
There were a couple of things. When I had my first UBM done to me, it was quite a jolting experience just because the water was so cold. Now we warm up the water before we do the water bath, and the last year I've been much more comfortable. But it's the only thing you can feel is really the temperature. And once the nurse gets the hang of how much pressure to put on, it's quite comfortable. I think from a patient point of view, it's the first time you've been lying down trying to be still. Sometimes that's a bit more nerve-wracking. I suppose also they still have that anxiety of, am I going to be suitable for this procedure? And their hopes are riding on the scan as well. If they've gotten through the UBM comfortably, then we know they'll be fine for the topical surgery, because the topical surgery is probably going to be a similar amount of time and they're not under a water bath. The water bath's the only thing that's a bit strange about it. Whereas if somebody's really finding the UBM difficult, then there's no point in putting them through a stressful surgery. If they're asleep, it's more comfortable for everybody. So that's a big advantage of doing this screening, because previously I can imagine we may have had some patients on topical where it's been more difficult than we anticipated, even if the patient seemed so relaxed in the consultation. Just when they have a speculum and suddenly everything changes.
That's the exact point I wanted to make. You've made it very nicely, is that besides giving us the best information on the sizing and predicting what we're going to get in terms of bolt and angle, it's been an amazing tool to guide us into which way. And the truth is, we're doing many more cases now under topical than we ever did before, because they're finding Guru overwhelmingly positive and nothing to it. They expect worse. And then we say to them, the surgery is pretty similar. And they decide to go with topical rather than anesthesia.
The other big change is we've been doing same-day bilateral for the last, probably 6 months or so, maybe a bit more. Topical, where we can do an OCT between the two eyes. But now if I see a Guru printout where there's a really big safety margin, I'm very happy to do same-day bilateral under DA. So immediately sequential.
I've done it a few times.
With the experience we've got with Guru, we know that it's going to be there or thereabouts. And if there's a good safety margin, there's no kind of hesitation in proceeding to the second eye before checking the bolt. It's been so accurate so far.
Yeah, absolutely.
I think we've had 86% of our cases within 200 microns of the predicted bolt.
86% within 200 microns.
Yeah. If you think the average eye take a volt between 50 and 800, that's a huge safety buffer on either side.
I think almost as important is that there've been no patients with very low volts and no patients with very high volts.
Yeah, exactly. So
more importantly, there've been no patients with angles that are threatening to occlude. They've been occluded. I'm almost more interested at this stage of my career in the angle, the predicted angle, than the volt, because the volt with the little aquaport, I think, is quite forgiving, but the angle accuracy, the predictability of that is such a useful tool.
If the volt is high, the surgeon feels maybe that could look better on our OCT and the patient's happy. But if the angle's low, you better remove the lens. There's a hard stop there. Avoiding a narrow angle is the only thing that is really a fixed thing that you have to avoid.
If you think about a patient where there are two lenses you can use, two sizes, but the lens is toric. If it's non-toric, it doesn't matter which lens you choose probably. But if it's a toric lens, you really want to use the bigger one to get a bit more of a fixation. But then you want to know, what does it suggest or predict the angle is going to be? And the level of confidence is just completely different to what we've ever had before.
That's just actually a really good point that I hadn't really thought of before, is we've always said this ICL Guru and the Sonomed UBM aren't likely to improve our visual outcomes. It's likely to improve our safety and confidence. But I think when we look in a few years' time, if we look back at our toric outcomes, they're going to be a lot more stable because we're choosing the lens that has the greatest rotational stability. It's not just based on what's the one lens that's going to fit. For many patients, there are 2 or 3 lenses that could fit, and we choose the one that is the lowest likelihood of rotating.
Exactly. And the latest version of ICL Guru, in fact, has an indicator of the rotational stability.
That's something that we should look at. So that, were there any specific cases you can remember where having the UBM and ICL Guru changed the plan, changed the decision making?
Oh my goodness. The very, very first case I did, this lady was scheduled for bilateral surgery on the same day. It was a Monday morning, and we had got the Guru on possibly on the Thursday or the Friday before. And so when she came in, she was a very nice lady and she was under topical, so I knew she was going to be fine. I said, look, do you mind if we just do an UBM on you? It's going to give us additional confidence, and it just gives the team an opportunity to try this machine out. And she said, yeah, absolutely, go ahead. And we did it, and we found that the size we had for the one eye was 2 sizes too big, and the other eye was 1 size too big. Plus, we found she had a small iris cyst. I just said to her, I said, look, I don't know how to explain this to you, but you've got this new device now. It's suggesting to me that the lens that we have for you is too large. And my advice is we're going to postpone this surgery, order new lenses for you, and do this on another day. She was very generous about it, very nice about it, and said, sure, no problem. And we ordered the new lenses, put them in on the same day, and they were within a few microns of what was predicted. So that changed. That very first experience we ever had almost signed the deal for me, although we need more experience to really make a decision. Now that we're well over 100 cases, we know how predictable it is. But that was the power. That day I understood the power. You've got a very interesting story too. I remember seeing a patient 5 years earlier, was very high myope with 6 diopters of astigmatism, but only at 2.5 millimeter anterior chamber depth. And I told her back then, there's nothing we could do. She was too young for a lens replacement, way too high for laser vision correction. I said, come back every now and then, and you never know. Just giving her some kind of hope, not anticipating we'd be able to do it. But what happened when she saw you a year ago?
Yeah, so a lot of change for her in those 5 years. She had become a mother twice. So she had a 3-year-old and a 1-year-old. And she came in and said, look, this is now something that I have to do something. I'm waking up in the middle of the night and I can't find the kids. I can't get to the cot in time. I'm tripping over things. Can't you just do as much laser as you can do, is what she said. So, can you take me? She was -16, -6. She said, can you just take me down to -10? So I just got back from Argentina and we had just got the Sonomed. So I said, look, there might be something we can do now. Your anterior chamber depth is way lower than the company recommends, but we've gone close to it before and been fine. I think it'll be nice to you to know if it is possible. Why don't we do a UBM and see what the AI predicts? Is there a lens that might fit? She was happy that there was something that we could potentially look at. We did a UBM, and there was one lens that was predicted to be in the yellow zone. So yellow is between 100 and 200 microns. So a little bit low but safe, whereas the other lenses were either hypervolts with closed angles or no volt at all. There was one kind of borderline lens. And I said to her, if we try and correct everything with the ICL and it doesn't fit because it has to go in at a very specific axis to correct your astigmatism, we know that if we get a kind of high volt with a horizontal ICL placement, we can rotate it vertically to lower the volt a little bit. And she said, what do we do now? And I said, what I would do if I were you is for us to correct the astigmatism with the LASIK. So bring you from -16, -6 just to -16, and then put in a spherical ICL. So we did the laser on the Tuesday, bilateral, plano -6. We did -6 on both eyes. I think one eye was -6.5, but we did the max we could. And then the following day we did the ICLs. And she's doing great. She was in the clinic last month while I was away, and she's 6'6" in both eyes. There's very few patients that I've seen that are so happy.
Yeah. What's interesting, you mentioned something that's very worth just repeating, and that is when you put a toric ICL in, you put one landing zone. It's going at that angle, and that's it. What you got is what you got. Whereas if you put a non-toric in, you've got the 3 landing zones or more horizontally. You win 150 microns if you go oblique, and you win 300 microns on average if you go vertical. So it gives you a lot more freedom. So that kind of freedom you just didn't have before, when you've got that power to do things.
The reality for her is that we would have not offered her anything if we didn't have this technology.
There's something I've thought about so many times when I've spoken about this, is that it's the same ICL we had 5 years ago. It's the same patient as 5 years ago, with the same dimensions.
Well,
The only thing that's changed is the fact that AI is now part of a UBM brilliant device. And those two together are giving such good predictions that you can start considering this. That's been the difference. That's the single difference why today she can see and is a totally different person as to 5 years ago, when we just said no, because we had no one on the planet almost would have had the confidence to in that space. I think she was 2.45. No one's going to be thinking about putting an ICL in there. And you went in there with confidence and a plan. You had the plan. You knew with a non-toric, you could rotate it and win some microns if you needed to. And the truth is, if I recall correctly, it went very strictly according to plan. You put it in horizontally. It was within microns of what you'd planned.
it's such a good perspective. 5 years ago, you would have been a total cowboy doing something like this. And now it's almost like bowling with the side rails off. Then to get to where you wanted to go.
It's doable now, for sure. All right. So, Brendan, let's try and share our experience of how we integrated ICL Guru and the Sonomet UBM into our practice. I think we've had it for just over a year, and it feels like now that we couldn't work without it. But can you just show how we integrated it into practice and how it now fits into the patient flow? At what point in the flow does this get done, and what are the tests do we do?
Yeah, of course. But when a patient comes in for a refractive evaluation, they're getting pentacam, topography, epithelial maps. And depending on their prescription, if the nurses think that they're a myope and they might be an ICL candidate, they also get an anterior segment OCT. And then they have their cycloplegic refraction, and we do their fundus exam, we do their surface exam. And at that stage, we will go through their options with them. And if ICL is the solution that's best for them, we'll recommend ICL to them. So we don't do UBMs on everybody that comes through the clinic, because it takes a while and it's nurse time that takes longer than doing a pentacam. But any patient who books in for an ICL procedure, they book in then for a UBM. It's usually 4 to 6 weeks before their surgery date. We can do it sooner, but we want to give ourselves a bit of breathing room for ordering the lens and potentially more discussion with the patient if needed. Once they've got a date, then we book them in for one of our Sonnet clinics that the nurses do. One of the other things that we've also integrated in is for our hyperopic cases, is doing their YAG peripheral iridotomy on the same day as their Sonomet. So they come and have the Sonomet right after the Sonomet, pilocarpate, and then we do the YAG PI. And for those really high myopes, we do a contact lens over refraction before their Sonomet. It's kind of an extra visit where we can just really refine things, and it fits in really seamlessly. The fact that the nurses don't have to go through all of the manual planning that was involved in OCOS, to just putting in the measurements, dimensions, and then getting the Guru printout there and then, means that they're doing less work on sizing now, but way more accurately.
Exactly. So up until recently, you're still doing OCT, we're doing the Nakajima formula, we're doing the Russo formula. So we have 4 things to make the decision. But the newest iteration of ICL Guru, the entire decision can be made just on the UBM.
Yeah. But again, we're not going to be doing UBMs on people that are booked in.
I understand, but you don't need all the other things to validate anymore.
No, exactly. They're only there just to prove that it was as good as the other previous ball style.
Yeah, I'm glad we had that overlap for a year where you could really see how compared to all the other things we were doing. But it's so good now that all the information you need is coming off the UBM. You don't need other information.
We would never have adopted a technology blindly. We were always going to do it in parallel with what we'd been doing previously until we could see it as good or better. that's what we've seen in the last year, is that there's nothing like it. There's nothing that gives us results like this in terms of predictive accuracy.
I really like the idea with hyperopes too, especially the +7s, +10s, a young patient with those kinds of numbers. Not many have very deep anterior chambers, and you don't have many options for them. And what's really helped now is the fact that we can far more predictably and safely put a lens into someone where previously we mightn't have done, within limits, obviously.
Speaking to other ICL surgeons, people that have done numbers way more than me, most of them have maybe a handful, a dozen of hyperopic cases that they've gone for, whereas I've done 6 already.
Because
It's just part of what I offer now.
I like our patient flow, where the patient comes in for their UBM, we find out, yes, you're suitable. We've got a lens size for you. So now we're going to go ahead. So you can go and have your PI now, and you're ready for surgery whenever. It saves them a trip to the clinic.
Yeah, very streamlined. If you were speaking to a colleague who wanted to start off in ICL, or if somebody who's experienced already was wondering about introducing ICL Guru into their clinic, what do you think are the main upsides to investing in this extra bit of technology?
Look, today, if you're entering now into the clinic, you're competing with people who are doing this for a while already, who've built up a clinic with a reputation. They've made the mistakes and they're not making mistakes anymore. And today, with you starting a clinic, you don't have to repeat those mistakes. In fact, look at where you're starting with ICL Guru. You're going to avoid mistakes that everyone else of us who's been doing it for a while have made. And you're going to have a much tighter sizing spectrum than what we've had over time. So what I would say to anyone doing it, there'd be 2 things. How many of our colleagues have you seen who aren't really proficient with diffractive multifocal IOLs decide to do one, get a very bad outcome, unhappy patient? I just mean an unhappy patient, not necessarily a bad outcome, but an unhappy patient. They say, not doing it again. In the LASIK days, when we used to make a flap with a microkeratome, and I think the flap I'm making, or I'm hoping the flap I'm making is 30, and we used to start measuring in 2000, we were measuring already, and the flap was in fact 200. Those kinds of surprises. I see ICL in exactly the same space. I see ICL Guru as giving us what femto LASIK gave us. Didn't necessarily give a better outcome in terms of uncorrected vision and best corrected vision, but it gave us this huge safety zone. We could treat people, more people were included now because we had a better safety zone. We knew the flap would be within 7 or 10 microns of what we're targeting. We know with Guru, we're going to be very close to what we're targeting. I personally, for today, can start doing it without having a UBM. There's no question about that. If you want to have the smoothest possible ride and the most positive experience of becoming a confident ICL surgeon, just do it right from the start. Why on earth would you first have a few cases you're sorry about, that you're unhappy that you did? Why would you have that before you invest in it? Why don't you just invest in it and avoid the problem altogether?
Here's an interesting way of thinking about it. This is the way that I would, if somebody asked me, should I get one? What I'd say is, think about it from the patient's point of view. If a patient knew everything about ICL surgery, would they ever go to a surgeon who's not doing UBM sizing? If there are 2 surgeons on the same road, same ICL, same numbers, and one does UBM sizing and the other one doesn't, and the patient knows the benefit, there's not a patient on the planet who won't go to UBM, using surgeon.
Brendan, that's a very good answer. You're 100% right. We do everything patient-centric, and that's a very patient-centric answer. You don't need to convince anyone. Exactly. The patient did the choice. They'd want the best information to make the decision.
Patients are getting more and more literate. Patients coming in, they know a lot about this. As ICL becomes more and more popular refractive surgery choice, people will know more about it. And I think if people look into it at all and they ask that question, it'll be difficult to defend not using it when it's a technology that's available. And as we've seen, we had never used UBM before. None of us had experience with UBM. Neither of us had experience with UBM. And within a week, we're using it to make decisions because the technology validates the scans for us. I think that takes so much of the hassle out of it. The fact that what I'm getting is a high quality scan and will give me an accurate outcome.
If you flip that question and say, would I be happy doing an ICL next week without the benefits of ICL Guru and Sonomed? My answer is no, I'm not doing it. I won't do it. I'd rather wait until we get the Guru. We're just not doing it now without that information. That's how crucial it's become.
You forget what it was like without it.
Yeah, exactly. All right, I think we'll wrap it up there. I'd like to thank you all for listening. I'd like to thank Sonomed for the opportunity and Brendan for the discussion. It's been really good. I just want to say that neither Brendan or myself are consultants for Sonomed. We agree to do this because we absolutely believe in this and we want to share our experience and make ICL more predictable and safer for everyone. Brendan, your last thoughts as someone starting out on this journey?
So ICL surgery can be daunting. And I think that starting with this confidence and the confidence that what I'm doing is going to be safe for this patient is something that I don't think I would have jumped into as much as I had without this technology. So if anybody's thinking of starting an ICL, the first question they ask is, what do you do about sizing? And the only answer I have is get a Sonomed and get ICL Guru.
Yeah, I think that's good advice. Well, thanks very much.
Thanks, that.